So I shall be focusing on the cystocyte quantification. So here is how I shall go about it. So we shall be discussing on what are they, how do they look, when to count them, in which conditions do we call them significant, and then followed by a few words on automation and digital morphology. So basically, its name is derived from Greek word cysto, that means broken or cleft. And they are circulating fragments of red blood cells or RBCs from which cytoplasmic fragments have been lost. And they are formed by mechanical damage to the membrane which is caused by fibrin strands on the endothelial surface and by turbulence of blood. So this is a short animation which shows a red blood cell traversing through the blood vessel and fibrin strand tearing it apart. So this is the same thing at a different plane. So basically, back then, way back, there was a lot of confusion or rather lack of consensus as to which cells we count as cystocytes. So ICSH in 2012 came up with recommendations on how to identify them, in which conditions do we call them, and how to quantify them. And this is the recent, couple of years back, 2021 update on the same. So basically, cystocytes are always smaller than the intact red blood cells and should be counted in 4 different types. So first type being the small fragments of varying shape, sometimes with sharp angles or spines, in which case we call them as triangle cystocytes, with straight borders, so sometimes with a round outline on one side, in which case we call them as microcrescents, often distorted, staining darkly or occasionally pale. So this is a microcrescent. The second type being helmet cells. We all know them. So these are helmet cells. Third type being the damaged cells, which are larger than smaller fragments, and they have a pair of spicules. They are separated by semicircular concave segment, sometimes even 2 or 3 pairs, and they are usually named as keratocytes. So these are how keratocytes appear. And this is the last variety. These are small sized hyperdense red blood cells with a round shape and increased staining, just like they seem as spherocytes. And most important thing is that they should be counted as cystocytes only in the presence of other types of cystocytes. So this is how they look. So this is a keratocyte, this is a helmet cell, this is a triangle cystocyte, these are microspherocytes. This is the helmet cell, this is a microspherocyte, this is a keratocyte, and these are microcrescents. So these are the type or scenarios where we don't call them as cystocytes. So these are spherocytes. In absence of other types of cystocytes, we don't call them. So these are irregularly contracted cells. These are acanthocytes. And these are sickle cells. In these scenarios, we don't call them as cystocytes. Please note that these sickle cells are larger than the surrounding red blood cells. So these are cystocytes, but these are not cystocytes. Again, these are triangle cystocytes. Likewise, these are not cystocytes, but this is a cystocyte. So like that. So the latest update of 2021 update states that standard procedures for smearing and staining blood films are essential. This is very important, as if we don't follow them, then we will see artifactual cystocytes. And the standardized count should be done, it is stable rather, up to 3 hours from the blood collection if it is at room temperature, and 8 hours if it is stored at 4 degrees. So how to count them? So first of all, we need to select an area where RBCs are just overlapping, and then we go into high power or oil immersion lens. We should not select the area which is at feathered edge where we see all spherocytes. And then we start counting the red blood cells and cystocytes, put them in the formula, and the recommendation is to count 1000 red blood cells. Now coming to Rumke distribution table, which shows confidence limits of an observed percentage of cystocytes depending upon the red blood cells counted. So as you can see here, if you consider true value of cystocytes as 1%, and if you count 100 red blood cells, there is a very wide range, 0 to 5.4. If you want to improve this precision, then we need to count more and more red blood cells. So 1000 is a good thing to do, and 10,000 is the best thing to do. So the recommendation is to count at least 1000 red blood cells and preferably 10,000. Now whether it is possible to count 10,000? Well, the answer is no, because an average time to count 1000 is estimated to be about 10 minutes. So if the real world application rather of 10,000 cell count is prohibitive in terms of balancing resource requirements to potentially exhaustive resourcing required to achieve better agreement. So 1000 is a reasonable cutoff, or rather the best balance between time and resources. But if we still want to count 10,000 red blood cells, there is an intermediate method that we can use. Of course, this is not a recommendation. What we can do is we can select an area where RBCs are just overlapping and homogeneously spread. We go into oil, and then this average field usually has about 200 red blood cells rather. We can count 50 such fields and obtain or reach 10,000 red blood cells. So suppose this is a field, then we can have an imaginary plane and then start counting the number of red blood cells. After counting the red blood cells, we can start counting schistocytes like this and then go on for other 50 fields. So then we can reach to 10,000. We can put that in this formula and we can get the percentage of schistocytes. So the clinical utility of schistocyte quantitation lies in distinguishing whether it is there or it is not there. Rather it is less than 1% or it is more than 1%. So ultimately the cutoff of 1% matters a lot. And this is the distribution of the type of schistocytes. As you can see, helmet cells and crescents, they are the predominant forms, while the triangular cells, keratocytes and microspherocytes are the less predominant forms. And it is not that you will see only schistocytes in only TTP and HUS, but you can see in all other conditions like hematological malignancies or megaloblastic anemias or metastatic carcinomas or sepsis or renal failures to infection to others also. So the presence of schistocytes, even if associated with severe thrombocytopenia, may not specifically identify cases of thrombotic microangiopathy. And the converse is also true, that lack of schistocytosis also does not exclude a diagnosis of TMA. So this is a very good example. This is a case of megaloblastic anemia. So you can see schistocytes here also, but surrounding you can see macrovalocytes, Howell-Jolly bodies, hypersegmented neutrophils. So you can be sure that this is not the predominant abnormality. So schistocytes here are not the predominant abnormality. So these are the upper limits of normal individuals. So in healthy adult, it is about 0.2%. In neonate, it is 1.9%. And in premature neonates, it is about 5.5%. So cutoff, or rather the presence of schistocytes is significant only in two settings. One is thrombotic microangiopathy, that is TTP or HUS, in which case the cutoff is 1%. And second is transplant associated thrombotic microangiopathy, in which case the cutoff is 4%. In all other conditions where schistocyte is not the predominant abnormality, we need to qualitatively grade it and mention in final report that it is not the predominant abnormality. And the recent update, that is 2021 update, states that 1% cutoff is there for adults and full-term neonates, and for premature babies it is 5%. So if you want to qualitatively grade it, it is less than 1%, 1 to 2%, and more than 2%, like that. So this is a Bland and Arpan plot which shows the correlation between different observers. So if you see at lower schistocyte percentages, there is good agreement. As you move higher, there is higher schistocyte count, there is less agreement among the observers. And this is the latest algorithm that is given on how to approach cases of schistocytes. So whenever there is a suspicion of TMA, or there is an automated FRC count which is positive, then we need to check whether schistocytes are there on smear or not, or by a digital scan. If they are there, we check whether it is the predominant abnormality or not. If it is not the predominant abnormality, still we are suspecting, if we have still strong clinical suspicion of TMA, we examine the film daily. In other case, we think of an alternate diagnosis. If schistocyte is the predominant abnormality, then we start counting them and report as we discussed earlier. Coming to automation, that is fragmented red blood cells. So they have a lot of advantage. There is good reproducibility. It counts lot of cells. It is available within minutes. Does not require an expert to report. And it has good sensitivity and negative predictive value. So this is important. It has good sensitivity and good negative predictive value. But it has limitations that often overestimates or underestimates the count. And it is quite well known. It's affected by hypochromia. It is low specificity, and it is not recommended to be used in isolation. So there are different analyzers which analyze FRC differently. This is one type in which the platelets are counted if the volume is less than 30 femtoliters and refractive index between 1.35 to 1.4, and RBC fragments or FRC corresponds to those with having refractive index more than 1.4. So if flag is triggered when it crosses a certain value. This is the second type of analyzer in which x-axis shows fluorescence and y-axis shows forward scatter. So first a gate is drawn, gate T, so that demarcates RBCs from platelets, and after drawing that, another gate is drawn, that is gate 1. So that shows the number of schistocytes corresponding to number of RBCs. And if there are lot of small red blood cells, also it offers a correction factor through another gate, that is microerythrocyte distribution area. So there are a lot of published papers on the range of FRCs, predominantly by one or two analyzers only. So a common cutoff we can use is 0.5%. So as I said before, there are a lot of false positives in FRC, but it has a very good sensitivity and very good negative predictive value, meaning thereby that if you get an FRC as normal, then you are quite reasonably sure that there are no schistocytes in the smear. So this was one of our cases. It was suspected case of HUS, and with treatment the schistocyte percentage decreased, and it quite well correlated with the schistocyte percentage with FRC and FRC absolute. So evidence-based statements are put forward which states that FRC results and flags are helpful screening test. The absence is a valuable parameter to exclude schistocytes on blood film. Many studies are still required to draw a reference range, and samples with positive FRC should be checked by optical microscopy. So once we get a positive FRC, we need to check by optical microscopy. Coming to digital morphology for schistocytes. So now we are already into AI era. So we have also installed MC80 in our lab, and it is really nice that it automatically scans, it differentiates into different RBC types, and it also quantifies them. So I just pulled out few cases just to show. So this was a suspected case of TTP. So in that MC80 showed 7.6%, and manually we got about 4.7%. So it slightly overestimates. As you can see, the round things that I've shown, they are not schistocytes, but still they are counted. This was another case suspected for HUS. We got 2.7%, and MC80 showed 3.3%. So it was kind of quite concordant. This was another case. This was concordant. It was 1.6 on the machine and 1.45 on optical microscopy. This was again 16.9 on MC80 and 12.9 on optical microscopy. So this actually overestimated. And this was 1.58 versus 3.7%. So we just plotted a bland and alternate plot, and if you can see, the MC80 actually slightly overestimates, but at lower percentages there is quite a good concordance, but at higher percentages it is not true. But it also flags cases of not TMAs, like we see here a G6PD deficiency. It had a lot of bite cells, but it counted them as schistocytes. This was a routine checkup in which it got a value of 0.5%. This was suspected to have a megaloblastic anemia, and it shows 0.8%. This was suspected dengue, but it counted a false area which showed gross overestimation of schistocytes. So this was a study that was performed on CellaVision, which showed a very high sensitivity but rather poor specificity, like we showed, and it also slightly showed higher values for schistocyte as compared to as compared to manual analysis. It showed higher values in automated analysis. So the bottom line is that it requires manual revision. Even in this paper, 2/3 of the schistocyte which was counted by the machine, they were not actually schistocytes. And the final count of schistocytes in that, about 1/4 of them were classified as other type of red blood cells, which were actually schistocytes. So I want to conclude saying that schistocyte count has a definite clinical value in thrombotic microangiopathy in absence of additional severe red cell shape abnormalities with a confident threshold value of 1%. So 1% is the cutoff. Automated counting of fragments is also recommended by ICSH group, but as a complement to the microscope, according to high predictive value of negative results. And finally, schistocyte pre-classification provided by digital morphology analyzers requires confirmation with the optical microscope. Thank you so much.
Yeah. Two things I want to say: that a fragmented cell is counted in the machine as a schistocyte, but a schistocyte has to be fully hemoglobinized. A
Yes.
fragmented cell may be hypochromic, it may be fragmented, but it will not be fully hemoglobinized. And that's why we see the discrepancy between the AI of the machines, which are only counting fragments.
Yes.
But a true schistocyte is a fully hemoglobinized cell. And that's why so far, I think we need to see the slides before we can call. Of course, the hemoglobin, how will you measure in these fragments?
Yes. So there are 2 points to your comments, ma'am. So basically, what you're saying is correct that we need to check by optical microscopy, and that is what the recommendation is. Whatever the machine gives, either it is FRC or either it is the digital scan. We need to confirm with the help of microscopy. Regarding hemoglobinization, our understanding at 2012 recommendations was the same as you are saying, but recently they have modified in 2021 as they also incorporate those cells which are falling into the criteria of all 4 types, but we are still having slight central area of pallor or loss of hemoglobin. They are still counting it, but there is a recent recommendation only in 2021.
Uh, Very good talk. I had a question. Like while you are saying that there are limitations and there may be so much of morphological variants of these fragmented cells, what is your protocol of commenting on schistocyte index in premature babies? Because many a times these pycnocytes come into the peripheral blood and people get confused whether to really count them as fragmentation or just mention them. So what is your take on the presence of pycnocytes?
First of all, thank you so much for your comment. Second thing is regarding the premature babies, the recent recommendation 2021 update states a cutoff of 5.5%. Like you said, there are pycnocytes that we see. I don't exactly remember. The Barbara Bain blood cells book mentions even a range for pycnocytes that it is agreeable to accept. So they also say that around 5% we can see cystocytes, which might include if it is falling in all 4 types. But still, we will keep a cutoff of 5.5% and not 1%.
Do you run FRC on these cases? Or it's just the morphological percentage you rely on?
So the thing is that I usually report NGS and stuff. The routine is not reported by me, but in our lab, whenever there is an index of suspicion, both ways, either it is from the clinician side or either it is from the pathologist side, they send me for an opinion, in which case I see. So they of course look at the routine thing. So I'll just share a small experience that before MCAT it was different and after MCAT is different. Before MCAT we used to like see all the smears, this and that. But after MCAT we now have started relying on the automated parameters and digital scan. So we can just in a snap have a look at it. Of course, it is not gold standard and we will have a lot of false positives. But kind of once we start using that instrument, we will start getting comfort zone and we will try and identify, or we will identify those cases which it is missing. So we will know where we need to be cautious and where we need not to be cautious.
Thank you.
We have another question from Dr. Rakshika.
This is regarding the schistocyte automated FRC count. Is there any false positive value that you have seen with cases of extravascular hemolysis apart from intravascular hemolysis? For example, in extreme anisopoikilocytosis associated with sickle thal or thalassemia, beta thalassemia major.
Yes, so definitely FRC count, it will means count that area in which RBCs will fall into that graph that I showed you. So in the cases that you are describing like sickle cell, you will have some microcytosis here and there. So RBCs will fall in that area. Even though the microerythrocyte distribution area will correct that thing, but it will not be able to correct so much. So definitely it will have false positive, and that is also reflected in the recommendation, in which case they state that FRC count is an sensitive indicator, but it is not a specific indicator.
Okay. I have a comment and a question from me. When Dr. Professor Gini was explaining and showing in the ISCSH his work, I asked her, what can be useful for the people that are not expert in cell morphology to see if they are real schistocytes or not. She told me that the presence of some spherocytes, because the pathway of the schistocyte is become spherocyte and after to be lysed. But my question for you is, which parameters from chemistry or immunochemistry can be helpful for the same, to suspect schistocytes, aptoglobin, indirect bilirubin, LDH? What is your experience about which parameters from the chemistry can help?
Yes, so the index of clinical suspicion comes from the clinicians. Basically, they look at, suppose they're thinking of renal failure, so a race create, along with signs of hemolysis that you are seeing NRBCs, the hemoglobin is dropping, the reticulocytosis is there. All these things like LDH, indirect bilirubin, all these cases here and there, there will not be like one thing, short for one thing, but a combination of all these parameters would help raise a clinical suspicion. And of course, when we look at smear, suppose hemoglobin is 7, we are looking at smear, we'll pick up schistocytes, not a big deal. But for those which are not experienced, like you are saying, for them, FRC count will be really helpful because they will flag that thing to be reviewed by an expert like that.
Thank you very much.